This episode of the Talking Health Tech podcast features a live recorded session from our recent Winter Summit, supported by THT Plus partners, data capture experts. We explore how the Loddon Mallee region has created a regional virtual care strategy connecting 15 health services to improve care for people with chronic illnesses and reduce hospitalisations. During the session, you'll hear what makes our THT Plus Virtual Summit special, because there's a lot of live engagement and interaction with the audience as they help us shape the conversation. Now, we're busy planning for our next virtual summit to happen later this year. Registration is free, and you can learn more on our website. Collaboration starts with a conversation, Team HealthTech. Let's make it happen. The Loddon Mallee region has taken a collaborative approach to their virtual care strategy, connecting all 15 health services in the area. This session will share their journey in reducing preventable presentations and hospitalisations for people with chronic illness. You'll hear about the lessons learned and the next steps in implementing their innovative virtual care functionality to enhance healthcare outcomes. This is session 2 of the Talking Health Tech Winter Summit 2024, titled Regional Virtual Care Strategy. Special thanks to data capture experts for bringing you this session today. In the discussion is Leanne Anderson, Chief Clinical Information Officer at Data Capture Experts, Katrina Neave, Manager, Loddon Valley Virtual Care Office at Bendigo Health, and Craig Simmonds, CEO and founder of Propell. Before this session, we ran a poll to find out what's the most significant benefit of a regional virtual care strategy. 56% of people said reduced hospital admissions, 20% of people said improved chronic care, 20% of people also said enhanced patient satisfaction, and 5% of people said cost savings. Maybe there's more to it. Let's go to the panel and find out. Maybe there's more to it indeed. Welcome to session 2 of the Talking Health Tech Winter Summit. The panel that I've got with me today is a great one. No strangers to Talking Health Tech, and I think a journey that we've heard about at different stages. And depending who you are, you might be familiar. It may be an entirely new one. But g'day, Leanne, Craig, and Katrina. Thanks so much for joining.
Perfect.
Morning.
Super duper. So, I feel like whenever I'm on a call with you, Craig, I just want to see what the gadgets are, and let's play with toys in the background. I don't know how you get anything done with all of that. But that's okay. But we'll hopefully hear about some of it shortly. But I might kick off for this session for Katrina. I think you're in the best position to kind of set the scene in terms of the journey that you've gone on in the Loddon Mallee region, and then we'll it will logically tie in Leanne and Craig into that discussion. So over to you.
Fantastic. Well, thanks for having us, everyone. The experience within the Loddon Mallee has been a fairly long and interesting one, and one that continues on with some really exciting things in our kind of work plan coming up. So the Loddon Mallee is a very well-connected region, and as you heard in that introduction there, I think the key factor for us and what sort of drives this work is true collaboration as a region. So the Loddon Mallee is 25% of the state. We have 15 health services. Some of those are very small health services. Others are the regional and sub-regional health services. So we've got a real range there. And there has been a very long history of collaboration that actually preceded the health service partnerships work within Victoria, which is wonderful. A part of that has actually been some long-term strategic investment in architecture, actually, and utilising the standards that we heard about from Phil and the previous presenters and the importance of those. Effectively, what that has enabled is that again, shared investment of a regional platform, which is the data capture experts product. Internally, we call it our regional community platform. It's actually been utilised for a range of things, including the day-to-day documentation and scheduling and everything for our community services. It's actually what connects our region to be able to do some really innovative, well, not particularly innovative, but to be able to do it as a region within the virtual care space. So we've had an opportunity to do a number of things, including manage our response to the COVID-19 pandemic at the time, where there was a significant focus, quite rightly, I suppose, in the metro setting. In the regions, that often has a bit of a lag. So we're in a position to be able to do some of that ourselves with that internal foundation already set. Also in the previous session, there was discussion about, leveraging what was learned from COVID. So building upon that is actually what we have done. So I don't think we've lost too much momentum within the Loddon Mallee. We actually continue that collaboration and that investment through the Better at Home program of work, which is also done quite collaboratively. So that shared investment into the clinical equipment and the integration of that clinical equipment has actually positioned us to be able to implement remote patient monitoring for all 15 of our health services. So it's really providing that equity across the regions. It doesn't matter where you live in our region, you'll have the same access to this. And obviously the health service benefits are, as was shown in the poll, we are seeing evidence of each of those things, and avoiding presentations is key. There's a lot of impact that happens at the system-wide level, not necessarily within that one health service, but keeping people home safer for longer is, really fundamental to what we do. So yeah, that's what we're up to.
Thank you, Katrina. Look, it's a great scene setter, and I want to come back to the point that you mentioned, some innovative things. Oh, they're not actually that innovative, and I think that's going to be a really important kind of thing to highlight too. Is that we're not trying to build Iron Man here, or I'm trying to think of a better example there, or do some crazy next level things, but some really impactful things that does require a lot of coordination with different parts. So, I saw co-design mentioned a few times in the previous session, Leanne, and I thought of you. But it sounds like, and I know you're familiar with how things happen, kind of on the front line too. Talk to me about how you worked with the region to be able to kind of put this thing together and make it actually something decent.
And that is the real key to it, is to make it something that's really useful and
Yeah.
effective for those clinicians that have to use it. So when Katrina and her team first come to us to say, look, we're really keen on setting up some remote patient monitoring, we're very excited. You'll hear from me every time I talk somewhere. I'm from regional Victoria. It's all about getting equity of access to healthcare for regional and rural Victorians for me. So that's sort of where I always focus on. So anything that does that, I'll jump on board with. But also we've already got, this regional community platform that's rolled out across the Loddon Mallee. So the system itself was already there and this health services had access to it. So that was a really great starting point. And then there was the purchase of the actual devices that Craig will talk more about. So the devices were available, so they're able to give those to the patients. So there's sort of those two first hurdles perhaps we'd already overcome. And then it was about really working with Katrina and her team to understand what is it that the clinicians really need and how will it work? And then conversely, what is it the patients really need and how does it work for them? So we did a couple of different sessions where we worked with clinicians to work out how they needed to access information, what was important, when it was important, what was the quick access sort of stuff. But then we also met with some patients in a couple of consumer groups and talked to them about what does the app look like and how should it work. And we went to them initially with an app that had 6 tiles on the front page, and universally that was too many. So we needed to reduce the number of tiles on the front page and things like that to make sure that the words were really simple and clear and could easily be understood no matter what sort of background they come from, and to make sure that it was really easy to hit, because those fingers and on those phones it's really hard to hit the tile that you want sometimes. So making it really accessible and the usability easy for those patients, but then working also again with the clinicians to make sure it did what they needed it to do, but then overlay that with good governance and make sure that the escalation pathways were there, that we understood the value of that data and where it was going to sit and how else it could be used. So all of that as a vendor, we can't do on our own. We have to do that with those health services and work closely with them to understand how it should work.
Yeah, absolutely. And you touched on this, the need for having some physical devices to be able to capture some insights from outside, from within inside, and also outside the hospital walls. I guess that's where Craig comes in. Craig, I'd love to hear from your side in terms of, I guess, how you kitted this thing out. What were the needs, and I guess, every week we've talked about this before. Every week there's something cool and new and exciting that can be brought in, I guess your role sometimes is to be that voice of reason of, well, and assessment of, like, well, there's a lot of ways you can collect this information out in the field, but, like, what's the right tool for you to be able to do that? I guess That's your jam, right?
Thanks, Pete. I've never been called the voice of reason. I must remind my wife.
You know, said it didn't fit perfectly, but I'm going to run with it. You know,
Yeah,
it's,
yeah.
trusted voice for sure.
Katrina was talking about innovation, like we're innovative, but we're not innovative. And this is actually, the devices that Katrina and Leanne use as part of the Loddon Mallee. We've got really innovative devices, but they're actually not innovative in any shape or form. I mean, all they are is blood pressure monitors and pulse oximeters and thermometers and scales. They've been around forever.
Yeah.
The difference is what happens with the way that they look, so the usability for the patient. So it's got to be really simple to use. But then also, you can get these devices anywhere, but it's about the data that comes from these devices. Because they're Bluetooth devices, it means we can get this information from someone in Mildura and someone in Bendigo can be monitoring it. And because of that Bluetooth and the way we integrate it into data capture experts means that Katrina and her team can monitor where they are. We've actually been doing this for a very long time. And once again, we're not innovative in that side. Prior to Loddon Mallee, we've actually been doing this in Katrina's area for the last 4 years. And we've been proving it in primary care and in the same hospitals that we're now doing with Loddon Mallee. And we've been doing it with patients and with hospital staff and nurses and GPs. And it's just them just getting used to the idea of the devices, which they do quickly. And if you make the devices easy to use, that's one less thing for the patient to deal with. And that helps the workflow, and workflow is really important. So look, the devices are simple. The beauty is now we just streamline it straight into data capture experts to make it easier for the clinicians to monitor.
Yeah. Although I that reminds me, I need to hit you up for one of those. I saw you at an event, and there was one that would match my earrings really well. I think it was a continuous oxygen one.
It is. It's in fact just yesterday they got FDA approval. It goes on the year, and that is so it does continuous monitoring, and that's something that we can take with Loddon Mallee. But let's bed down what we're doing well first, and then we extend it because it's just getting people used to it. So yes, it will match your black.
Excellent. If you get it in black, I'm all in. But the back to Katrina, so we've got the context, we've got the parts, we've got the things to be able to do it. And it sounded like there was, as Leanne mentioned too, there's, iterations and you progressively evolved over time. It's great to be able to have that relationship. You touched on it already, but I want to kind of hone it in, in terms of the impact then for, and we saw in the poll too, you've got benefits all round, which is a great story. It doesn't come without a lot of work to do that. In terms of the bring it to the patient side, because in the end, yes, you got to demonstrate the return on investment. You got to make sure that the clinicians are, are in a situation can still operate and hopefully operate better than, and staff too. It doesn't create already even more pressure on burnout and things like that too. But at the patient level, are we really seeing that this has an impact kind of on outcomes? And
Yeah, we are, and it is still quite early days. We haven't got this rolled out to all 15 of our health services yet in the non-admitted setting. So we're going to continue to obviously monitor and track that. And we've got, as you would expect, an evaluation piece underway in a partnership with the university as well, actually. I might hit the chat with the link. We've got a scholarship open if anyone fancies a second PhD in your spare time. There's one of those going with us at the moment. So we absolutely are seeing really significant impact for patients, and we will absolutely continue to capture that in the data. But what's really heartwarming is actually the individual stories that we're capturing as we go. So there's some really powerful things that we've been able to capture that then actually helps with that, supported adoption to new health services as the virtual care office comes to them to go, okay, this is what we're offering and this is what it will do for your patients. We are in that unique position because we're using a regional platform and we've already invested in the clinical equipment. We actually get to go to the health services and go, hey, guess what? This doesn't cost you anything. We also don't have to have that constant financial justification of having X number of patients monitored per month to then meet a KPI to be able to prove that financial investment. So that I acknowledge is very unique, but we're very grateful for that. The patient stories are very important for us to continue to capture, to be able to share that with others. But we've seen some really, particularly with the patient portal, it came up in the previous, session, and I know from previous work that putting patient information in their hand is so, so powerful, no matter how limited that information is. So at the moment, the patients have within the patient portal their biometric readings, the ability to message with their clinical team, the ability to respond to a clinical survey, which provides their clinical team back with additional information, including the impact that RPM is having on them. So patient-reported experience and outcome measures is all captured within the system. So our clinicians can send those periodically and capture that information, which will obviously help us well with our evaluation over time. But just the really simple things like a patient going to Melbourne from one of our regional health services to her appointment and going, here's my information, and handing it to the doctor to be able to scroll through. It's simple, as we were talking about before, and are we innovating or not? The way I keep describing this is that we want to do simple really well and do it everywhere and make it available equitably across our region, to then look to see what we can do on top of that and how we can continue to broaden that benefit and that impact out. Yeah.
Let's do simple really well. I think that's a key message that many can take away from this particular session. You touched on the fact it's in the regional area, and Leanne, you talked about your passion there. I saw Katrina in the chat here mention that it's important to build that collaboration and trust to be able to have good change management across stakeholders. I'm interested in the panel's view in terms of, is some of this success because we're working with a close community? I guess I say close. It's a regional area. It's geographically a lot of room. But are there variances? I guess you've seen across different settings there, Leanne. Is some of the secret here being regional and rural, or is it just depends on the location?
It does depend on the location, but I will say for the regional areas that we've worked with, those regional health services work really closely together because they know they need to support each other because their patients come from far and wide, and those patients might one day turn up in Mildura, but the next week turn up in Swan Hill. And so they know they've got to work together. It's sort of a bit of a necessity that they just do that. And therefore they have committees that allow that collaboration and that relationship to build. So being able to sort of work with them as a collective is actually easier in some ways in the regional setting because they already have a structure for doing that in their current state. So in some ways, that's actually an easier thing. But the other side of it is that those patients live 4 or 5 hours away from a health service. So there is a greater imperative, I think, to put these things in place so that those patients aren't travelling every few weeks to have their blood pressure taken. And equally, you can't afford to send nurses out that far either, every couple of weeks to take a blood pressure. So you've got to sort of think of different ways to do those things. And so being able to provide that kind of service to a patient means they don't have to leave work, they don't have to get off the farm, they don't have to leave the kids for all those hours to get to those appointments. If they don't really need to, then you've got this alternative for those cases. So in some ways, the imperative is just higher in the country. So I think we do it well because of that.
Yeah. Sticking on that theme for a second there, Lauren, g'day Lauren, by the way, great to see you. Has brought up the question that does pose a challenge often in more rural and remote locations is the issue of connectivity. Interestingly, later in the summit, we're talking about the network infrastructure more at a hospital level. But actually, Craig, I'm interested from your side, just from the device point of view, in a lot of parts, whilst internet's pretty good in Australia, there's and it's certainly improved over the years, that connectivity piece can always be a blocker. Where does that kind of fit in with devices?
Yeah, I think it's a perceived blocker. I don't think in the scheme of things it's a major concern. We've been doing this for a long time now, and regional and rural is a major part of how we've been using these devices. If anything, it's been it's sometimes the problem is the biggest blocker is not internet connectivity. It's actually just clinicians getting used to doing it. It's a different way of doing it. The patients always accept it, and we know our studies, and one of our studies from the Loddon Mallee area showed that patients who are over the age of 80 are far more willing to engage in this type of technology and way of monitoring than younger people under the age of 80. So the older you are, the better you are. So we've proven that side. We don't seem to have the issue with connectivity per se, as in the internet connectivity, because it's getting so much better. It's just a change of way of doing things. And as people get used to it, they're far more accepting.
Yeah, that can often be one of the biggest challenges, is that that technically the thing works, but if there's multiple steps in configuring or getting the thing set up. But I guess that's that's reassuring to hear that from the patient side, it's probably more the clinician side that's the can be a challenge of doing things in new ways. As Jody pointed out in the chat, innovation means new to you, not necessarily new to market, which is another good little one-liner, which we'll totally steal. Katrina, I saw somewhere in the chat, there's great activity happening there. Keep those coming through, people, if you're attending live. But I feel like that's not the one that I wanted to draw out. No, I will come back to that one though. But Monica mentioned the, providing financial benefit or return on investment, open to anyone in the chat here. I guess, Monica's pointed out, it can be difficult to demonstrate return on investment for preventative health. I guess because if something hasn't happened, how do you talk about, the value of that investment in it and the saving that you've made? Thoughts from the panel in terms of demonstrating return on investment of some of these initiatives, if the major benefit is preventative health or something that might not be easily measured or demonstrated?
It is difficult to demonstrate it in terms of a KPI that sits on one health service CEO's dashboard, because often in our setting, where we might be preventing an ED presentation for the larger regional health service up the road versus the urgent care centre that they're closest to. So it is the business case doesn't write itself. I'm very aware of that. The system impacts, it really is cost avoidance. As opposed to cost savings, particularly, in our health, in our region, there's a lot of health services that are block funded. So they're effectively funded to do the work anyway. So back to Craig's point, in terms of doing work differently, where it is a bit more demonstrable that there are service efficiencies are actually within the non-admitted settings. So things like a hub or complex care service, in theory, can have more patients on their program with the same resourcing because they're not physically going out to see as many patients. We are also working with each of the health services as we implement remote patient monitoring to make sure that they've optimised their use of telehealth. That despite, all of the last however many years now of pushing that, hasn't really permeated in all of the ways that, you would think. So optimizing that at the same time and connecting that with remote patient monitoring is really powerful. I think telling people to use telehealth is one thing, but connecting it with a model of care and demonstrating the value from a service efficiency perspective is really important. Again, we've had an opportunity to look at it as a whole of region, but even doing so, it's effectively asking senior leaders to look at it as an asset, as opposed to it being a something that has to have a return revenue stream on it each year until the funding mechanisms catch up. That's not the case.
Yeah. No, that's a great one. I can see here in the chat too, David's pointed out in other locations around the world that there's some good, I guess, collaborations with other stakeholders in relation to infrastructure, making sure they got connectivity in rural parts, so to make sure remote patient monitoring is accessible. And as I mentioned, we're talking about connectivity later on at the summit here. Leanne, as we're hitting about, the time goes quickly in a summit session, and I wanted to reserve some time to have a bit more of a future-facing thought. And I'll come back to Loddon Mallee in a second, and Katrina's already touched on one or two things that they're continuing to work on in terms of where you're seeing across your broader user base or this region too, where you see the biggest needs are in terms of the services you provide, and what can we look forward to seeing from the data capture expert side?
Yeah, look, we're working with other customers in different care settings, and sort of mental health and community health and district nursing type settings, where they're also interested in this kind of work because, again, they can see more patients with less staff, so that getting that that overall capacity sort of growing as it needs to, because what we've learned is we can't keep building hospital beds, right? So the best next thing we can do is keep people out of hospital. How do we do that? We provide good community-based services. So our real sort of purpose at the moment is really finding ways to support those community-based services, because often, and often in hospitals, particularly in Victoria, we've gone out, well, actually everywhere in reality, we've gone out, we've bought EMRs. EMRs are fabulous inside the hospital walls and the inpatient bed-based care, but they don't often help with the community care or the mental health care and those things that happen outside those inpatient units. So we're really focused on that area, because I think that's the area in health in the future where we really have to focus on, because we can't keep building beds. So there's a real need there. So we're absolutely looking at ideas where we can send surveys, so regular surveys, particularly to mental health patients, so that they can use the patient portal app again and complete those surveys on a regular basis and be sending those back to their clinicians for review. And you can aggregate some data there over time as well. And so looking at different ways to use those patient portals for different cohorts to collect different data. But often it's really just about how do we monitor those patients well at home so they don't get so sick they need to come into hospital. And so really that's the focus of most of the work that we're doing at the moment.
Excellent. Thank you, Leanne. That ties in nicely then, Craig, in terms of some of the work you're seeing and the solutions you're helping bring to market. We've said that keeping it simple and ensuring that stability, and also the getting relevant approvals, and think that's half the battle sometimes. What's exciting you about some of the cool new devices that are on the horizon?
Yeah, Pete, I'm really conscious of, there's a lot of stuff that comes out, but one of the things I've learned is you've got to make sure it's very much focused on the patient so that the patient can use it almost on their own. And at home, as Leanne just said, everything has to be focused at home, not in the hospital environment. So that differentiates products, because sometimes there's lots of gadgets that come out and go, oh, this is really cool, but really it needs a nurse or even a doctor to engage with the patient, which we don't want to do. We just want to, ideally, we want to send the device to the patient's home. They open the box, they set it up, and they're ready to go, like within 30 seconds. That's the gold standard. So any device that we do, it also has to be scalable. And by that, I mean, when Loddon Mallee they don't want to have a device that can just do to 20 patients. They need one that can do to thousands of patients. There is limited funding. So if you're going to do something, get it out to as many patients as possible, not do this amazing device that we can do a small cohort, which is really great, that if it's only doing 20 or 30 patients, who cares? We're not interested in that. We need scalable health devices. That's the best way to describe it. Get it out to as many people as possible.
Yeah, and thank you. And Richard, who's well familiar with general practice within that rural location, is on the same page as you there. Katrina, in terms of some great success so far, and appreciate the update in terms of where things are at. Like, where's your focus at Loddon Mallee now, and things you're working on?
Yeah, so having set the foundations in the non-admitted space, we're moving into the admitted areas with hospital in the home and gem at home. So of the 15 health services, we have 5 of those have got HIT services. So we're looking to enable those HIT services and gem at home services with remote patient monitoring, which by definition really creates virtual wards. So looking to see then operationally how they can then be integrated with emergency departments, for example, and really doing some, learning and benchmarking from others that are doing that well within the state of Victoria already, and across the country. South Australia are doing some really cool things. So effectively virtual wards will be the focus coming up, both from the perspective of enabling hospital in the home services, but also from the perspective of, I mentioned a number of our health services are fairly small scale. So there is also the opportunity to utilise virtual wards to be able to support people to be cared for closer to home and still have that specialty care that they need provided, but perhaps provided from one of the sub-regional or regional partners within the region. So those are the big ticket items for us at the moment.
Love it. Well, look, we've hit time, but it's been wonderful to hear about a real example of implementation of some of these technologies, both on the software and the hardware side, and hearing it from the region firsthand. I also love that this summit is certainly bringing out the one-liners from the chat here. Christian has said that a good user interface is like a joke. If you have to explain it, it's not that good. So that's a solid one. And I saw Jody as well as brought out the classic that Australian Health has more pilots than Qantas. So on that note, I'm going to leave it there with this panel and join one that it ties in quite nicely. So Leanne, Craig, and Katrina, thank you so much for your time.
Thanks, Pete.
Thanks.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.